So it's been a pleasure to think about doing this trial because even though guidelines tell us specifically as clinicians what are we supposed to do with these patients, how do we treat these patients, and even though we can share that with our patients, we find that in the US we are not following guidelines as closely as we should be. So we're not treating patients with the medications that guidelines tell us we should preferentially treat them with. And even though guidelines say that the patients should be treated for a year, we're finding that our patients are stopping their treatment before the year's up. When we found out a little bit more about this, why this is happening, cost was a big reason that was frequently cited for why we were not able to follow guidelines. So we hypothesized that if we equalize the cost between the brand medication versus the generic medication, that it would accomplish a couple of things. One is clinicians would feel like their hands are less tied. They can actually prescribe the treatment that they felt would be best for the patient, as opposed to the treatment that they think that the patient can best afford. Patients could now be able to say, my doctor told me to take this for a year, I better take it for a year because I don't have a reason not to now from a cost standpoint. And at the end of the day, clinical outcomes would be improved. So we did this trial where we recruited about 11,000 patients in 300 hospitals. In all of these patients had an acute MI, and all of these patients were treated with a medication. And all of these patients were enrolled before they left the hospital. And in all of these patients, the treatment decision was left entirely up to the treating physician. So we didn't change that at all. But in the 300 hospitals, half of these hospitals got usual care, which is current practice in the US, and half of these hospitals, they were able to give their patient a voucher. So the patient would take the voucher, go to the pharmacy, fill their prescription, and instead of paying the copay of the prescription, the voucher would pay for it for them. So that's the major intervention. And then we followed these patients for a year to see how they were doing. So we found that it significantly changed how we practice medicine. So from a physician standpoint, because we took cost out of the equation, now physicians were more likely to prescribe the treatment that guidelines tell us that we should be prescribing. So that was win number one. Win number two was the patients. So with this intervention, more patients are now able to stick to treatment for longer periods of time. And we measured this a couple of ways, because if you ask a patient if they're taking medications, often they're overestimating their own treatment. So we assess this by asking the patient. We assess this by looking at the pharmacy fill. We're checking to see if the patient actually went to the pharmacy and picked up the medication. And then in a random subgroup of patients, we drew blood from them to make sure they actually put it in their mouth and took it. And it didn't matter which way we measured the patient. The intervention arm patients always did better than the usual care arm patients. So that was win number two. Finally, and this was the surprise of the study, we expected, we won on number one, we won on number two. How come we didn't change clinical outcomes? Because our clinical outcomes, unfortunately, did not differ significantly between the intervention arm and the usual care arm. And the reason for that was possibly the fact that 28% of the patients in the intervention arm were given the voucher but never used that voucher. And when we looked at that group of patients who never used the voucher, these happened to be the patients who were least likely to adhere to guidelines and had the highest rate of major adverse cardiovascular events. So the lesson learned from us is, if we're going to implement something like a copayment reduction strategy, we need to make it really easy for the patient. So even a voucher isn't easy enough. Now, we had to use a voucher in the US because, unlike the UK, everyone's insured by a different insurance company, and they have different policies, and so we needed to adjust for all of that. But that required a patient to take the voucher to the pharmacy, hand it to the pharmacist, everything goes smoothly, and then the patient can get their medication for the lower cost. But what if it was a back-end strategy? So the patient goes to the pharmacy to fill the medication, and on the back end, the pharmacist already knows this is an important class of medication. I need to drop the copayment cost down because that's what would benefit what the patient would benefit from. And in that scenario, hopefully we would see that difference in outcomes. And we actually saw a hint of that in this study. In the as-treated analysis, the two curves did start to diverge, showing an improvement in the intervention arm. That wasn't significant at the end of the day because we didn't quite anticipate that 28% of these patients wouldn't do that. It does, because I think we could learn a lot from your healthcare system. The U.S. healthcare is a very complex system, which means that if we want to change something, we need to somehow change it across multiple stakeholders. And in the UK, it may be simpler to do that because you have a national healthcare system. But what we learn from this is we just need to make it easier for patients. Reducing the cost is an excellent strategy that seems to improve clinician prescribing behavior and patient medication taking behavior. So now how do we incorporate that into the health system and then study that to be able to say, if we implemented this more universally over millions of patients as opposed to 11,000 patients, then I think we might be able to see those outcome differences that we're truly hoping for. Well, I think we need to think about copayment reduction as one of many strategies, because if you ask the patients who never use the voucher, why did you not use the voucher? Some patients may say, well, payment is one of my barriers to taking medication, but it's not the only barrier to taking medication. So the next research should really look at copayment reduction as part of a multi-pronged strategy to try to improve medication taking behavior as well as clinical outcomes.